Welcome to ATCM, the Emergency Medicine channel. Shall we start, sir?
Yes.
A 60-year-old male patient came to ER with history of altered behavior, restlessness, and confusion since yesterday night. On initial 10-second assessment, patient was conscious but not oriented to time, place, and person. Airway patent, no pooling of secretion. Breathing respiratory rate 14 rate per minute, SpO2 99 on room air. Circulation heart rate 62 per minute, BP 120 by 70 mmHg. Disability GCS was E4, V4, M5. Pupils equal and reactive. GRBS 100 mg per dl. Exposure afebrile. On initial assessment, we'll have a differential diagnosis as either hypoglycemia, hyponatremia.
Basically, an altered 60-year-old male with altered mental state. Okay. The first thing to be ruled out is
Hypoglycemia.
hypoglycemia. Okay.
Patients.
If ABC, everything is fine.
Fine.
Because hypoglycemia is in D, right?
D.
GRBS. Because if ABC is fine, you are in D right now. Then GRBS, GCS, pupils. GRBS is 100.
100.
Okay. GCS is E4.
E4, V4, M5.
M5. Okay. The total will be
14 by 15.
E4, V4, 13.
13
by
15.
Okay. All right. Pupils?
Pupils equally and reactive.
All right.
Now-
You're not suspecting any IC bleed as of now for the time being.
There is no rise in ICT features or rise the
Okay. There is
hypertension.
no pupil asymmetry as such.
Asymmetry and isochoria not present.
And in circulation also BP was
BP is
also on the
also
normal side.
normal side.
If it was an IC bleed, it should have
Elevated.
gone up. Okay. And there is no history suggestive of a trauma to the head or
Head
anything
or
of
no
that sort.
history.
Okay.
And now we'll have to rule out the other causes of altered sensorium, hypernatremia.
And temperature is also fine.
Fine.
So
Febrile.
hyperthermia, hypothermia, these things are not there. But hyperthermia, that can also cause some altered mental state. Okay.
Adjuvants
NMS
to
and things like that. Okay.
next is hyponatremia. For that, we took adjuvants to primary survey VBG. On VBG, there was respiratory alkalosis. pH was 4.8. PCO2 was 30.2.
VBG.
VBG.
Okay.
HCO3 is 20.1.
pH, how much?
7.48.
48.
Mild respiratory alkalosis.
Yeah. Normal range is 7.35 to 7.45. So
7.45.
it is alkalosis. All
Yeah.
right. So the question is whether it's respiratory alkalosis or metabolic alkalosis. So okay. So what is the PCO2 and
PCO2 is 30 and bicarb is 21.1. Mild respiratory alkalosis.
But this was a VBG, right? So we
VBG.
can't rely on the PCO2 in a VBG. If it was an ABG, then you could have told it's PCO2. PCO2 and VBG is not reliable. Ideally, you should have taken an ABG and see to identify what exactly the problem is. It respiratory or metabolic? Okay.
Sodium is
Respiratory, it was normal, right?
yes, sir. 14 rate per minute.
Okay. So if the respiratory rate was high,
High. We
then
could yeah.
ABG should have a what? what
Hyperventilation causing
If I do like that continuously for 1 hour, what will be the ABG like?
respiratory alkalosis because of carbon dioxide
You're
washout.
hyperventilation and you're like washing out all the PCO2.
PCO2.
Right? Okay. Then
Sodium was 138.
and
So
if the respiratory rate was low, suppose it is 8, then what will you expect? ABG.
acidosis. Respiratory acidosis.
Respiratory acidosis you expect, right?
Hypercapnia.
Because unable to wash out the thing, and PCO2 will naturally keep on going up. Patient will become drowsy, and ultimately you may have to intubate it. Okay, that happens usually if the respiratory center is all gone.
But usually ammonia
Yeah.
will stimulate the respiratory and can cause hyperventilation.
Okay.
Sodium was 138, so we ruled out hyponatremia. And
In VBG.
yes, sir.
138.
138.
Okay. Sugars. 100.
Sugars 100.
Okay.
So we ruled out hypoglycemia, hyponatremia.
So no need to check corrected sodium and all.
There is no history of intake of alcohol, so we ruled out alcoholic intoxication.
What was the lactate value?
Lactate was 4.4.
4.4. Okay. So it's lactic acidosis.
Lactic
is there.
acidosis.
Okay. So what could be what are the reasons for lactic acidosis? Is it Hagma or Nagma?
It's an Nagma, sir. Normal non-handicap metabolic. Lactic acidosis.
Okay. All right. Okay, go ahead. Let's see.
So we ruled out hyponatremia, hypoglycemia, hypercapnia, alcoholic intoxication because there was no history of alcoholic intake. Then we'll have to rule
But
out.
he's an ethanolic CLD, right?
Yes, sir. But he has stopped drinking since last 2 years.
Last 2 years. Okay. All right.
Next, we'll have to rule out, as you told, we'll have to rule out IC bleeds, SAH and SDH.
For how long he's an
Altered sensory.
CLD? Like CLD duration how much?
Around 5 years. Sir.
5 years. And he stopped alcohol 2 years back.
2 years back.
What child C?
Child C.
All right. Okay. Go ahead.
And also we'll have to rule out any infection causing.
So in this background of CLD, you are expecting hepatic encephalopathy.
Yes, sir.
Okay. This background. This primary survey is all clear.
Clear.
And there is no pupil asymmetry, bleed and everything is ruled out. Then moving on to
Secondary
survey. Only CLD, no other co-mobs.
Hypertension and dyslipidemia.
Hypertension, dyslipidemia. Okay. So possibility of a stroke is also there, right?
Yes, sir.
Ischemic stroke is also there.
But there is no hemiparesis, facial deviation, slurring of speech.
Okay. So no neurological
Deficits.
focal neurological deficit is not there. So you are like still you are sticking on to your diagnosis of hepatic encephalopathy.
Yes, sir.
Okay.
Coming to secondary survey.
But he is moving all limbs.
No ataxia present. He came by walking. He's just having.
You wrote 13 GCs, right? E4.
V4 M5.
M5. So came by walking means it's not fitting into the M5 means it's. So that's wrong. That aspect is wrong. M5 means?
Patient localizing the pain.
Yeah, you try to give pain and patient will come and try to remove
it.
Otherwise, simply a patient who is walking, lying on the bed, he's got full GCS. You can't say he's in NCUF. Okay.
Coming to secondary survey, patient is a known case of decompensated CLD with portal hypertension, type 2 DM, dyslipidemia and HCC in segment 8 since last 5 years. Now patient came with complaints of altered behavior, restlessness, confusion since yesterday night, history of altered sleep habits present since last 4 days, history of constipation since last 2 days, no history of abdominal pain, abdominal distension, melena, hematemesis, or any infective focal.
Why you are asking all these things?
We'll have to look for the precipitating factors of hepatic encephalopathy.
So what all things will cause hepatic encephalopathy in case of CLD?
Precipitating factor, primarily it can be an upper
this
GI
case it is constipation. You're
constipation.
saying it's constipation.
Yeah.
Okay.
Causes are either an upper GI bleed, dehydration, electrolytic imbalance like hypokalemia, hyponatremia, infections, spontaneous bacterial peritonitis or any URTI or LRTI can cause. Yeah.
Okay.
And or excess
Why
dietary.
should hypokalemia cause?
Hypokalemia will cause
Hepatic infection.
reabsorption of ammonia in renal tubules.
Okay. So are you coming to the discussion of the?
Yes, sir. Hepatic. What is hepatic?
And also hypokalemia will cause gastric mortality
Delayed.
will be
Yes.
delayed. So finally it will again cause constipation. And then finally it will cause hepatic encephalopathy. Okay.
Hepatic encephalopathy is a complex neuropsychiatric syndrome characterized by disturbances in the consciousness, behavior and personality changes either due to failure of liver to detoxify the toxic agent, either because of hepatic insufficiency and or due to photosystemic shunt.
You didn't tell about this thing, no? That systemic examination.
Coming to systemic examination.
Just told the rest of the history you didn't.
Yes, sir.
mentioned?
Coming to allergic history, there is no allergic history as of now. Past history, decompensated CLD with portal hypertension, type 2 DM, HCC in segment 8 since last 5 years. Coming to systemic examination, CNS S1 S2 was heard, no murmurs. CVS S1 S2 heard, no murmurs. On coming to CNS, GCS was E4 V4
In the case of altered this thing behavior, you're the first system that you should be mentioning. is
CNS.
You shouldn't be straight away going telling about CVS, RS, GIT, and finally CNS. In this particular case, I think CNS will be better than GIT because this is a CLD case. Then you move on to CVS, then RS, like that.
Pupils equally and reactive. We could not look for flaps because patient was little drowsy, was not obeying commands.
This case is a case of drowsiness. So in your history, you have got three approaches. Either you go with Socrates approach, Odipara approach, or Who approach. For pain-related complaints, you go with Socrates approach. That means site, onset, character, radiation, associated symptoms, timing, exacerbating relieving factor, severity. Whereas if it is not pain, you go with Odipara. That means onset, duration, intensity, progression, previous episodes, aggravating relieving factor, associated symptoms. So that you don't miss out on major points. In a case of altered, like sudden collapse or sudden altered sensorium, then you'll have to think go with Who approach. Who saw it, when it happened, where it happened, what happened before the event, where was he, what was he doing before that, how long this episode lasted, when did he become normal, was there any associated trauma, head injury, got it, no? Like that. Okay. This being a gradual onset of altered sensorium, I think you can better go with Odipara will be better. It's not a sudden onset. It's not a sudden event. If it was a sudden collapse or it was a sudden seizure, things like that, syncope, you would have gone with Who approach. Who saw it, where it happened, when it happened, things like that. Whereas this being a gradual onset, I think that Odipara will be much more apt for this kind of presentation. So if you go according to that, you won't miss out on major points. Got it.
Then we could not check for any cerebellar signs since patient was drowsy.
Other history, family history, other history is all fine.
Yes, sir.
Personal history.
Personal history, he has stopped
Social
alcohol
history,
since last
social
2 years.
history.
No history of smoking.
Okay, family history, nothing.
Family history, nothing significant.
Okay.
After coming to a conclusion,
okay. This thing, hepatitis, serology status and all, is it fine?
yes, sir.
What is the cause of HCC? Like serology, hepatitis B, HCV, everything is fine?
Yes, sir. HbSAg was negative. Serology was negative.
Negative, all right. Okay. So what is the plan from gastro side for this HCC part? Are they planning anything like?
No.
Is it a palliative kind of care or is it a active?
Plan from...
Okay, leave it.
Okay. So from our side, patient since had 2 days of constipation, we gave him loose enema stat. Post which a patient...
So how do you treat hepatic encephalopathy?
The modality of treatment mainly involves, first we have to correct the precipitating factors. Then you will have to prevent the recurrence of hepatic encephalopathy.
Okay.
For precipitating factors, as I have told, it can be either an upper GI bleed, excessive dietary intake of protein, a renal failure, constipation, electrolytic imbalance, drugs, or infections, or alcoholic intoxication. So we'll have to treat accordingly. Now, in this case, the patient is having constipation, so we are going ahead with loose enema stat. And for to prevent further recurrences, we'll give him a dietary plan. And
ammonia level has been sent?
Yes, sir. It was elevated, 41.2.
Okay.
So, in order to prevent the recurrence of such episodes, we'll give him a dietary chart and...
counts are all count. What about the counts? CBC, CRP, point of care?
Total count was 6.9. Platelet was 53,000. HP was
of CLD.
CLD. Patient's baseline is around 53.
Okay.
HB is 15.1. CRP is only
15.1 means you're not expecting bleed.
Yes.
Any like melena?
No, sir. No history of melena hematemesis.
Okay.
Patient had previously or 4-5 months back an history of upper GI bleed, melena.
Okay. CRP?
CRP is only 2.3.
Okay, so there is no infection as of now. You are
No.
thinking solely about constipation as a cause of precipitating hepatic engulf in a SEC related CLD case. Okay, so you gave loose enema. So what?
Yes.
Okay.
After giving loose enema, patient had become symptomatically better. Then we
Within
had
what time beginning?
within
In ER
one.
itself, he became better.
No, sir. We have given. We had taken the patient to
Gastromedicine.
to the procedure room. We had given enema. Then only was shifted to gastromedicine. We had
Okay.
informed gastromedicine on call.
Okay. It will take a few days before he becomes
Yeah.
normal. With one shot of enema, engulf can't resolve.
Not completely
Around
better,
2 to
but
3 episodes of loose stools should be there per day. Maybe like for 3-4 days only, for a period of few days only, everything will get resolved. Okay.
then treatment mainly involves giving a proper dietary plan, rifaximin 550 mg. This is to reduce the ammonia producing gut bacteria. It's given BD dose 550 mg. And also syrup lactulose. What syrup lactulose will?
That is in the ICU, right? All these things
Yes.
will be given in the ICU.
Yes.
Okay.
So syrup lactulosis will reduces the pH in intestine, will reduces the number of ammonia producing bacteria, and also helps in conversion of this toxic product into ammonium ions, which can be easily absorbed.
Okay.
Grading of hepatic
What is
engulf.
that grading called?
West Heaven criteria.
Best having. Okay.
Grade
Previously,
0.
it was a separate grading. During my times on, it was a separate grading. Nowadays, recently, I think maybe like around like 8-10 years back, only this West Haven classification came up in the literature. So, what is West Haven classification? Usually, it will come may come as a recent update in hepatic encephalopathy. Even though it came around 10 years back and all, I've seen papers asking about West Haven classification in recent updates. Okay.
So grade 0 is no abnormalities. Grade 1 altered sleep, mild confusion and disoriented sleep. Grade 2 is lethargy, moderate confusion and flaps. To check for the flaps, we have to extend both
Like
the and dorsiflex the wrist and tell him to close his eyes and wait for 5 seconds.
Will like flaps will be there. Okay.
Now coming to third grade, patient is drowsy but arousable, marked confusion will be present. Grade 4 coma.
Okay. So grade 4, what is the purpose of grading hepatic engulf? Why should we grade hepatic engulf?
If it is more than grade 4, patient will have other
Airway
compromises.
Airway
Will have
compromises
to
a possibility. Grade 4.
intubate.
There should be an objective way to tell. Like if I say grade 4, you also should say grade 4. There shouldn't be any confusion. If I say grade 10, you shouldn't be telling grade 4. So there's an objective way everybody will understand. And if it is grade 4 and all, usually it may require intubation because chances of airway compromise, vomiting, all these things are there. Okay. And furthermore, the thing is, you have to you have given a treatment. You should know the progress of your treatment, whether it's engulf is increasing or decreasing, whether you are going in the right direction or not. If it is despite giving all these anti-hepatic engulf measures, if it is GCS is still worsening, you should think about something else. Then you may have to go do further imaging. Probably you may have missed some other major diagnoses like meningitis, things, other things, bleed, all these things. Because CLD cases will have coagulopathy also, high chances of bleed also. And people will usually be found unresponsive on the floor. We don't know whether the patient has hit his head or anything of that sort. History will be like that. Okay. Then?
Clinical features, it can be either a disturbing other causes other than CLD, other causes of hepatic engulf are either chronic parenchymal liver disease, chronic hepatitis, drugs can toxins, transjugular intrahepatic portal systemic shunt, or acute viral hepatitis also can cause hepatic engulf.
Okay.
This ammonia, can cross blood-brain barrier. What happens is colonic bacteria will break down the dietary proteins, releasing ammonia. This will cross the blood-brain barrier, get converted to glutamine, and can cause irritation in the brain and swelling of astrocytes, causing cerebral edema and increased intracranial hypertension. So patients might also have in acute hepatic viral hepatitis. Patient can also present with raised ICP features also. We'll have to give him raised ICP measures.
What measure?
We can give anti-edema measures with either mannitol or 30% NSL can be started. Patient head and elevation to 30 degree. And we can
so
also...
this is the pathophysiology of postulates of this thing, hepatic encephalopathy, ammonia. That's the most common hypothesis regarding hepatic
encephalopathy.
Okay.
And other clinical features are...
Does the value of ammonia correlate with the hepatic engulf, like grade of hepatic engulf?
No.
Okay. Then? That's all?
Yes.
Okay. That's all we need to know. What are the definition of hepatic engulf? What are the differential diagnosis of hepatic engulf?
In emergency, what we should rule out.
We should do, stabilize ABC, everything. If at all you find out hepatic engulf is the cause, send for serum ammonia and all. Treat the precipitating factor of hepatic engulf. If it is sepsis or hypokalemia, or if it's constipation or upper GI bleed, treat it accordingly. And early gastromedicine intervention. Then
prevention of
recurrence of that usually it can't be done in an emergency department. That has to be done in the
gastromedicine,
ICU. What nutritional deficiencies, things like that can be addressed. But it would usually happen in the ER because patients hardly stay here for around 5-6 hours, and then you don't have time for that. Okay.
Thank you.